Hello everyone, welcome to Raaonline. I'm Dr. Aditi, I'm a consultant in internal medicine at Mehta Hospital, Chennai, and today in our endocrine system module, we are going to learn about the adrenal glands. So I'm going to focus predominantly on these four syndromes. So we're going to discuss in detail about the Cushing syndrome. We're going to talk about mineralocorticoid excess, the various syndromes behind mineralocorticoid excess. We're going to talk about an approach to incidentalloma, and we are going to end it with discussion on adrenal insufficiency. So this is going to be a very focused session where we're going to focus on these four topics, and let's start off our discussion with Cushing syndrome. Now, Cushing syndrome is essentially a clinical diagnosis. This is a constellation of clinical features resulting from chronic exposure, long-term exposure to excess glucocorticoids of any etiology. So essentially, even exogenous glucocorticoid intake can result in Cushing's syndrome, Cushingoid features over a period of time. So, what are the different causes of Cushing syndrome, which is essentially a clinical diagnosis? The most common cause, as I just mentioned, is going to be exogenous steroid intake. So, the most common cause is iatrogenic Cushing's. So, could be for various autoimmune disorders. Sometimes patients may be prescribed a short course of steroids, and patients may end up taking these medicines either inadvertently or consciously, and that's going to result in Cushingoid features. And in such an individual, if we do not get the history properly, we are going to go around in circles without picking up the iatrogenic cause as the etiology behind the Cushing syndrome. Now, the most common cause of Cushing's per se is exogenous. But the most common cause of endogenous Cushing's is going to be a pituitary corticotrope adenoma. So, an ACTH secreting tumor in the pituitary is the most common cause of endogenous Cushing's. So, overall Cushing's, exogenous Cushing's is the most common cause. Amongst the endogenous Cushing's, pituitary Cushing's, which is also called the Cushing's disease, that's the most common cause. Now, pituitary Cushing's is seen in females more commonly than in males, and whenever it does occur, it is a microadenoma, and it occurs more commonly in a sporadic fashion than when it is being associated with genetic syndromes like MEN1. We've discussed Cushing's disease, pituitary corticotrope adenoma in detail in our discussion on pituitary gland, so I'm not going to go into that in detail. Now, ectopic ACTH is another important cause of Cushing syndrome. Now, both pituitary Cushing's and ectopic ACTH secretion are driven by ACTH production. They are going to be driven by excess ACTH. Therefore, they are called ACTH dependent Cushing syndrome. So, ACTH dependent Cushing syndrome can be divided into pituitary Cushing's, which is called the Cushing's disease, and ectopic ACTH secretion. Now, pituitary Cushing's is more common among females, whereas what is more common among males is the ectopic ACTH secretion. Now, the most common cause is going to be lung carcinoids, particularly bronchial carcinoids, and followed by thymic carcinoids and pancreatic tumors. Finally, adrenal tumors make up only a small proportion of the endogenous Cushing's. More common cause of adrenal Cushing's is going to be the adrenal adenoma, and then you can have other causes like adrenocortical carcinoma. What is PBMAH? PBMAH is primary bilateral macronodular adrenal hyperplasia. It was also referred to as AIMAH. So, AIMAH is ACTH independent macronodular adrenal hyperplasia. So, this is a macronodular state. Now, PPNAD is a micronodular state. So, this is primary pigmented nodular adrenocortical disease. So, these are all distinct diseases. We will discuss about them in detail when we talk about the ACTH independent adrenal Cushing's. So, ACTH is going to be suppressed in adrenal etiologies of Cushing's. Therefore, these causes are known as ACTH independent Cushing's. Now, what are the clinical features in Cushing syndrome? Because of the glucocorticoid excess, there is going to be gluconeogenesis and lipolysis, and this is going to contribute to the central obesity and impaired glucose tolerance, which plays an important role in characterizing the Cushingoid features. There is also going to be an increase in the protein catabolism. Now, what happens? 11-beta-hydroxysteroid dehydrogenase 2, which is this enzyme is responsible for converting the cortisol, which is the active form, into the inactive cortisone. So, what happens when there is excess cortisol? This enzyme is going to be overwhelmed. Therefore, this excess cortisol can go and act on the mineralocorticoid receptors, thereby resulting in mineralocorticoid effects like hypokalemia, metabolic alkalosis, diastolic hypertension and edema. Then what is going to happen? There is going to be a suppression of the pituitary. Now, because of all the glucocorticoid excess, there is going to be a suppression of the pituitary, suppression of TSH and the gonadotropins is going to occur. Now, this is typically how a Cushingoid patient looks like. So, the patient has central obesity, has a buffalo hump which is characterized by a dorsal neck pad, has a protuberant belly with purplish wide stretch marks, usually more than 1 centimeter wide and deep. These striae are characteristic of Cushing's. In addition, they are going to have this moon-like facies, rounded facies, showing you that there is facial edema. In addition, there may be features of hirsutism in the form of extra facial and body hair. And there is going to be facial plethora, thin skin and easy skin bruisability. All these makes up a Cushingoid habitus. Now, what are the prominent clinical features? As I said, just to recap the same things, moon face and buffalo hump as a part of central obesity. Skin shows broad purplish striae, acne may be there. There may be features of hirsutism and easy bruising. In the bones, there is going to be osteoporosis and an increased predisposition to vertebral fractures. In the muscle, there is going to be evidence of proximal myopathy. There is going to be impaired glucose tolerance and increase in the levels of the cholesterols. Patients are also going to have diastolic hypertension, edema and various neuropsychiatric effects. In addition, patients may present for the first time with certain complications of Cushing syndrome like infections or hypercoagulability states. Now, therefore, because of this wide range of clinical manifestations that I just spoke about, we need to keep our eyes open whenever we have a patient with premature osteoporosis, whenever we are seeing a patient with a new onset metabolic syndrome, rapidly progressing, patient with a polycystic ovarian syndrome. So, in all these patients, whenever we are seeing these patients who fit into this diagnosis, we always need to keep a diagnosis of Cushing syndrome in the back of our heads. In addition, there may be several other clinical mimics of Cushing syndrome. For instance, patients with diabetes, obesity, metabolic syndrome, depression, polycystic ovarian syndrome, all of them may have central obesity and therefore their physical habitus may resemble a Cushingoid habitus. So, these conditions are clinical mimics of Cushing syndrome. However, although clinically they are going to resemble Cushing syndrome, when you do a screening test like a 24-hour urine-free cortisol or overnight dexamethasone suppression test, the screening tests are going to be normal in these clinical mimics. So, the screening tests are going to be normal. Now, there are another category of conditions which are called pseudo-Cushings, where the screening tests are going to be mildly positive. Therefore, we cannot rely only on the screening tests in this group of patients. Why is this? Because in these conditions, there is going to be activation of hypothalamic corticotropic releasing hormone, and that is going to result in mild hypercortisolism. Now, what are these conditions which can result in pseudo-Cushings? So, we can divide them again into conditions which have clinical overlap with Cushing syndrome. For instance, pregnancy, depression, alcohol dependence, morbid obesity, poorly controlled diabetes mellitus. These conditions are not only clinical mimics, but they are also going to be biochemical mimics. Screening tests are going to be positive. These conditions, stress, malnutrition, anorexia nervosa, intense exercise, excess of cortisol binding globulin, all these conditions, what are you going to find? Often the biochemical tests, the screening tests are going to be normal, but when you look at the clinical features, the typical clinical features suggestive of Cushing's may not be present. Now, how do you diagnose a patient with Cushing syndrome? So, there is a very nice stepwise approach to diagnosis of Cushing syndrome. What is the first step? So, as I told you earlier, the most important cause or the most common cause of Cushing syndrome is going to be exogenous Cushings, iatrogenic Cushings resulting from exogenous glucocorticoid intake. So, the first step is targeted at ruling out exogenous Cushing. So, step 1 is a 8 AM cortisol. If the 8 AM cortisol itself is suppressed in a patient with typical Cushingoid features, that means this patient has an exogenous or an iatrogenic Cushings. Now, suppose if the 8 AM cortisol is not suppressed, if it is going to be more than 5 microgram per deciliter, if it is less than 5 microgram per deciliter, then what are we going to do in these patients? We are going to ask them for history suggestive of steroid intake. So, review the history and review all the medications and prescriptions. If the cortisol is not suppressed, then you put them through screening tests. Now, there are 3 screening tests, and if any 2 out of 3 are positive, that means Cushing's is likely. But remember, I told you about pseudo Cushing's situations like pregnancy, depression, diabetes, stress, anorexia nervosa, all these can cause physiological mild hypercortisolism. Therefore, screening tests may be positive in these conditions which come under pseudo Cushing's. Therefore, we need to do other confirmatory tests. So, first let's look at these screening tests before going on to the confirmatory tests. What are these 3 screening tests? First, we have 24-hour urine-free cortisol. The cutoff is going to be 400 microgram per day. If it's going to be more than 400 microgram per day, then cortisol excess is likely. If it is going to be less than 100 microgram per day, that helps us to rule out cortisol excess. Now, 24-hour urine-free cortisol is particularly going to be helpful in patients who are pregnant, in patients with epilepsy, because in patients with epilepsy, anti-epileptic drugs may interfere with dexamethasone suppression test. That's why this may be a good idea, and in patients with cyclical Cushing's. Now, the second test is going to be a midnight serum salivary cortisol test, where the cutoff is going to be 1.8 microgram per deciliter. So, if the serum cortisol taken at midnight is going to be more than 1.8 microgram per deciliter while the patient is sleeping, that means the cortisol is unsuppressed. Similarly, if the patient is awake and the midnight serum cortisol is going to be 7.5 microgram per deciliter, then that tells us that this patient likely has cortisol excess. So, the values that I mentioned here refer predominantly to serum cortisol values. Now, then you have the overnight dexamethasone suppression test. This is a very convenient test because the patient is advised to take a single tablet of 1 milligram of dexamethasone and 8 hours at night at about 11 PM and 8 hours later in the morning around 7 or 8 we do a cortisol. If that cortisol is not suppressed, the cutoff is 1.8 microgram per deciliter. So, if that cortisol is going to be more than 1.8 microgram per deciliter, then we can rule in cortisol excess. That means there is presence of cortisol excess. This test is going to be very useful in patients with adrenal incidentoloma and in patients with chronic kidney disease, because that's one of the few conditions where 24-hour urine-free cortisol measurement may not be adequate, because one of the major prerequisites for 24-hour urine-free cortisol is normal renal functioning. So, these are the 3 screening tests. So, if any 2 out of 3 are positive, then we will have to move over to our third step, which is the confirmatory step. Confirmation is done with something that's called the Liddell's test. What is the Liddell's test? It is the low dose dexamethasone suppression test, where we give the patient 0.5 milligrams of dexamethasone. This is given at 6-hourly intervals for 48 hours. So, totally the patient takes 8 tablets and totally the patient takes 4 milligrams of dexamethasone. So, 2 milligrams into 2 days is what is being consumed, and at the end of 2 days, the next morning, if we do a 8 AM cortisol on the patient and if the 8 AM cortisol is not suppressed, if it is more than 1.8 microgram per deciliter, then we confirm Cushing's. So, although there are many tests, this cutoff of 1.8 is the magic number that needs to be remembered, because both for midnight serum cortisol when the patient is sleeping, for overnight dexamethasone suppression test, and for low dose dexamethasone suppression test, for all these 3 tests there is a single cutoff. So, if it is more than 1.8 microgram per deciliter, that means the cortisol is not suppressed. So, if it is more than 1.8 microgram per deciliter, that means Cushing's is confirmed. This patient has Cushing syndrome. Now, the next important step is, so 3 basic steps to confirm a diagnosis of Cushing syndrome. You start off with the 8 AM cortisol. What do you understand at the end of this step? Whether it is exogenous or endogenous. If it is endogenous, you move to step 2 and you screen for Cushing's. If screening test is positive, that means there is cortisol excess. Now, we have an important responsibility to rule out pseudo Cushing's. That is where the Liddell's test, the low dose dexamethasone test, step 3 comes in handy. So, you do confirmatory test, and if low dose dexamethasone suppression test is positive, this is definitely Cushing syndrome. So, once you establish a diagnosis of Cushing syndrome, the next important question is, so far we were trying to answer whether it is Cushing's or not. Now, we will have to answer where is this Cushing's. Is it in the adrenal? Is it in the pituitary? Is it ectopic ACTH secreting tumor somewhere in the body? As I mentioned in the etiologies, all of this could be the reason behind the cortisol excess. So, that is where step 4, 8 AM ACTH comes in hand. So, once Cushing's is confirmed, the next important question is going to be where is the Cushing's, and for that we divide Cushing syndrome into 2 broad groups, whether Cushing's is ACTH dependent or ACTH independent, and therefore we need to do a serum ACTH. If a 8 AM serum ACTH is going to be less than 5 picogram per ml, that means this is suppressed. If it is suppressed, this is a ACTH independent Cushing's. Therefore, the problem should be in the adrenal and patients may require an adrenal imaging. If the ACTH is going to be in the grey area, 5 to 15 or 5 to 20 picogram per ml, this is equivalent. Still, it is not suppressed. So, the problem may be in the pituitary or in a tumor which is secreting ACTH. Therefore, we need to do either CRH stimulation or a HDDST. CRH stimulation is a corticotropic releasing hormone stimulation test, and HDDST is the high dose dexamethasone suppression test to see whether the problem is in the pituitary or in the or whether it is an ectopic ACTH secretion. Usually, if the problem is in the pituitary, then the ACTH levels will be less than 200 picogram per ml. It will be unsuppressed but less than 200 picogram per ml. If it is more than 200 picogram per ml, then usually we are dealing with an ectopic ACTH secretion. So, let's first discuss a little bit about the ACTH independent causes of Cushing syndrome. So, here the problem is in the adrenal. So, this contributes to 10% of patients with Cushing syndrome. The most common ACTH independent Cushing syndrome comes from adrenal adenomas, and therefore a CT adrenal is going to be the imaging of choice. And how do you go about managing these patients? Managing is with surgical removal of the tumor. Now, other causes of ACTH independent Cushing's includes an adrenocortical carcinoma. Now, this is common in the age group of 40 to 50 years. This is when it is seen. And when should we suspect an adrenocortical carcinoma? You have an ACTH independent Cushing's patient with an adrenal lesion, but the clinical features are significant for rapid course and virilization. These two specific attributes should make you think of an adrenocortical carcinoma. And on the CT, the features that are going to help us in distinguishing benign from malignant includes, one is the size, a size cutoff of more than 4 cm likely to be malignant. Similarly, CT attenuation, so if it is going to be more than 20 Hounsfield units, again likely to be adrenocortical carcinoma. Then there is a Weiss histopathological scoring which is used, and a score of 3 or more on a score of 7. So, basically what all are the criteria that are assessed on histopathology to evaluate adrenocortical carcinoma? The number of mitosis, whether it is abnormal mitosis, the number of tumor cells per hyperfield, capsular invasion, necrosis, all of this is assessed, and they are given a score of 7 totally. On a score of 7, if the scoring is going to be 3 or more, then it makes a diagnosis of adrenocortical carcinoma likely. Now, what are the other rare ACTH independent causes of Cushing syndrome? One is what I was telling you earlier briefly, which is primary bilateral macronodular adrenal hyperplasia. So, remember, this is going to be characterized by larger hyperplastic nodules which are distributed across both the adrenals. There is going to be enlargement of both the adrenals, and this is seen in the age group of 50 to 60 years. Now, in these patients, the response to exogenous ACTH is going to be very high because of adrenal hyperplasia and enlargement, and most most of the times these patients are going to be positive for aberrant receptors like vasopressin, angiotensin receptors, or all of these gastric inhibitory peptide, all these aberrant receptors may be positive. So in a patient with an ACTH independent Cushing's, you have bilateral large adrenals, some nodules here and there. Check for aberrant receptors because you may be dealing with autoimmune macronodular adrenal hyperplasia or primary bilateral macronodular hyperplasia. Then we have another entity called the primary pigmented nodular adrenal disease. Now here, in contrast to PBMAH, this disease is going to be characterized by smaller nodules. So there is going to be micronodular hyperplasia, and in contrast to the macronodular hyperplasia, which occurs in a much later age group, this occurs in an earlier age group. About half of these patients present before 15 years of age and the rest of them present before 30 years of age. This is going to be insidious. Sometimes when you notice cyclical Cushing's, it could be PPNAD that's behind it, and this may be associated with Carney's complex. Carney's complex may also have additional atrial myxoma and spotty pigmentations. On the CT, because these tiny nodules against an atrophic cortex is going to give the appearance of a string of beads, and here when you do a sequential low dose dexamethasone suppression test followed by a high dose dexamethasone suppression test, and then on day 6 you do a urine free cortisol, there is going to be a paradoxical increase in the urine free cortisol. So this is what is seen in patients with PPNAD. So whenever you have this string of beads appearance and you have an ACTH independent Cushing's or suspecting PPNAD, doing a sequential low dose dexamethasone followed by high dose dexamethasone suppression test and check a day 6 urine free cortisol. If there is a paradoxical doubling, then likely to be PPNAD. So let's move on. So we've discussed about the ACTH independent causes of Cushing syndrome. So when ACTH is suppressed, the cutoff is 5 picogram per ml. It is ACTH independent Cushing's. The problem is in the adrenal. These patients are going to require adrenal imaging. Now what happens when the ACTH is not suppressed? When the ACTH level is going to be above 5 picogram per ml, then two tests are going to come in handy in helping us understand whether the problem is in pituitary or likely to be ectopic ACTH secretion. First is the high dose dexamethasone suppression test. The rationale is that although there is ACTH excess, if the source is from the pituitary, these corticotrope adenomas, they still retain their responsiveness to the negative feedback mechanism, whereas the same cannot be said of ectopic ACTH secretion. That's the rationale. Therefore, when you give dexamethasone, when there is an adequate suppression, that means it is probably the pituitary, because it is the pituitary corticotropes that have retained their negative feedback. So how is this done? So remember, in the low dose dexamethasone suppression test, a dose of 0.5 milligram of dexamethasone Q6H for 48 hours was used. So here 4 times as much. In the high dose dexamethasone suppression test, 2 milligrams given every 6 hours is used. So 8 milligrams per day for 2 days, total dose of 16 milligram per day. And you check an 8 AM cortisol. The 8 AM cortisol needs to be suppressed by more than 50%. So if the suppression is by more than 50%, that means compared to the baseline, you have a level which is less than 50% of the baseline, then you're looking at pituitary Cushing's. Suppose the suppression is inadequate, it is not 50%, then your 8 AM cortisol is going to be more than 50% of the baseline. In such an instance, you're looking at probable ectopic ACTH secretion. However, remember, sometimes this negative feedback may be mimicked by bronchial and thymic carcinoids, PPNADs and pheochromocytomas. So remember, these are the other important false positive causes for a positive high dose dexamethasone suppression test. Now there is a easier modification. Sometimes what happens when we are evaluating these patients in the outpatient clinics, it's very difficult to do these tests over a 48-hour period. So therefore, there is a test called the overnight high dose dexamethasone suppression test, where you give a single tablet of 8 milligrams of dexamethasone and then the next day morning you take a 8 AM cortisol. And you interpret it in the same manner. If the suppression is to less than 50% of the baseline, then it is pituitary. If the suppression is to more than 50% of the baseline, then it is ectopic ACTH secretion. So for instance, what am I trying to say? You have a 8 AM cortisol already. Let's say your baseline 8 AM cortisol is 30. Once you do a high dose dexamethasone suppression test, the suppression is by more than 50%. So the value is going to be less than 50% of the baseline value. If that is the case, you are looking at pituitary. If the value is going to be suppressed by less than 50%, or when you look at the entire value, that value is going to be more than 50% of the baseline value, then you are looking at ectopic ACTH secretion. Now, what is a CRH stimulation test? Human CRH is given at a dose of 100 micrograms, and at 15 to 30 minutes, we check a ACTH. Usually, when the human CRH is given, the ACTH increases by more than 105% of baseline. When the ovine CRH is given, it increases by more than 40% of the baseline. Similarly, at 45 to 60 minutes, we look for ACTH increase. If human CRH is given, the increase is by more than 40% of baseline. If it is ovine CRH, the increase is by 20% of baseline. So, if there is an increase, that tells us that again the rationale is the same. It is the pituitary that's going to retain the normal responsiveness to CRH. So, you are looking at pituitary Cushings. So, but remember, about 10% of the times the pituitary tumors may not respond to CRH. Similarly, in about 20% of the cases, although it is a ectopic ACTH secretion, there may be responsiveness to CRH. So, we have discussed about ACTH independent Cushings. We've discussed about the grey area where high dose dexamethasone suppression test and CRH stimulation tests come in handy in helping us find out whether we are looking at pituitary or ectopic ACTH secretion. So, if HDDST, if high dose dexamethasone is positive, then we are looking at pituitary Cushings, and pituitary Cushings is called a Cushing's disease, and we need to do a pituitary MRI. So, usually these are corticotropic adenomas. As I said earlier, we've covered this in detail in our discussion on pituitary, and the treatment of choice is going to be surgery. Whenever there is going to be a mass effects, or when it is associated with a large tumor with hormone hypersecretion, we are going to offer transphenol surgery. Now, what is the role of inferior petrosal sinus sampling? That's what IPSS stands for, inferior petrosal sinus sampling. Now, whenever there are going to be discordant values, then IPSS is going to be helpful. For example, your HDDST is positive. That means the problem is in the pituitary. But then your pituitary MRI is normal or shows a very tiny lesion. In such an instance, IPSS will be helpful. So, first of all, we need to measure the prolactin, and this is used as a validation parameter to ensure correct placement of the catheters in the inferior petrosal sinus. First of all, this can be done only in places where there is very high level of expertise with this complicated procedure. So, once the prolactin measurement tells you that the position of the catheters is normal, then we look at the petrosal peripheral ratio. So, if the petrosal peripheral ratio is going to be more than 2 at baseline and more than 3 following CRH stimulation, that tells you that we are dealing with pituitary Cushings. In addition, when there is a lateralization ratio, what is a lateralization ratio? Let's say right and left inferior petrosal sinus catheters, you check if the ratio is going to be more than 1.4, then that helps you in lateralizing the tumor to the right side. So, that helps in with respect to localizing the tumor further with respect to the side. Now, this is how inferior petrosal sinus sampling is useful, particularly when you have a discordant HDDST with a normal pituitary MRI. Now, in patients with very high levels of ACTH, particularly when high dose dexamethasone suppression test is negative, we are going to think about ectopic ACTH secretion. In addition, these patients may have further clues in the form of significant hypokalemia and hyperpigmentation. So, as I said, in patients with ectopic ACTH, the ACTH levels are going to be very, very high. That's going to drive a significant excess glucocorticoid production, and that is going to overwhelm not only the glucocorticoid receptors but also the mineralocorticoid receptors, resulting in significant mineralocorticoid effects in the form of hypokalemia. Not only that, all this ectopic ACTH is going to be associated with increase in the secretion of ACTH precursors like pro-ACTH and POMC, and that's going to contribute to hyperpigmentation. So, when you have this kind of a syndrome, think about ectopic ACTH secretion, and as I said, the most common cause is going to be bronchial carcinoids, followed by small cell lung carcinoma and then pancreatic neuroendocrine tumors. So, often a CT of the chest plus or minus the abdomen is going to be helpful. Other tumor markers may also come in handy when we are looking at ectopic ACTH secretion. In case CT does not pick up, other imaging modalities like whole body PET CT or somatostatin receptor scintigraphy may be helpful. And how do we treat for all these patients, whether it is adrenal Cushing's, pituitary Cushing's or ectopic ACTH secretion? You have evidence of Cushing's and you have a tumor sitting there, then surgical removal is the definitive management. And following removal, remember that irrespective of where the Cushing's may be, it takes a short while for recovery to occur, and it occurs only in some instances. When I am saying recovery, I am talking about the recovery of the hypothalamo-pituitary adrenal axis. So, that needs to recover to for ensuring continued production of glucocorticoids and mineralocorticoids. So, what happens is, it's been found that ectopic ACTH secreting tumors after removal have the best recovery rates of HPA axis, up to 80%. That's followed by 60% recovery rates with the pituitary Cushing's disease, and then finally the ones with very low recovery rates are the adrenal Cushing. So, even if excision of just the adrenal tumor is done, recovery rates with adrenal Cushing's are the lowest. So, when we talk about medical management, this is predominantly reserved for individuals where immediate surgical management cannot be offered. So, what are the drugs that are available? Metyrapone and ketoconazole are the drugs which have been available for the longest duration, and metyrapone is used primarily because of its utility with respect to inhibition of 11-beta hydroxylase. Ketoconazole again inhibits a very important early step in steroidogenesis. Other drugs include mitotane, etomidate, pasireotide. All these drugs can be used in patients with Cushing syndrome who are not surgical candidates or in whom there are features of cortisol excess to such a severe extent that and where surgery is going to take quite some time. In such individuals, we can tide over the initial phase of cortisol excess by using these adrenolytic or anti-adrenal agents.